Good afternoon, everyone. My name is Peter Sador. I'm a pediatrician here at West Park. And we're kind of doing two topics today, and I'm going to be doing the first one, which you've probably heard a lot about in the news, the Zika virus, which is an emerging infectious disease with a lot of information and misinformation flying around. So I'm going to try and update you the best I can with what we know so far. And not to cut to the chase too much, but the good news is here in Wyoming we don't have too much to worry about, which I will elaborate on. So despite what you may hear, this is not a new virus. This was discovered in Uganda in 1947 in a monkey. It's named after the Zika forest, which has actually become one of the premier viral research areas. Got a lot of other emerging diseases from that region. The first human case was confirmed in 1952. And then after that, we didn't really realize or hear too much about it. So really quick, and not to get overly technical, it's an RNA virus. If you remember your biology, DNA codes it, RNA translates it, and then makes it into proteins, which are the little building blocks, the physical, actual part of the virus. It is a virus, so it can only replicate inside a cell. It cannot live independently. And that's what separates it out from a bacteria. What we have here is a little picture of it, obviously very, very magnified. And it's a very simple little organism. Each of those little colored boxes on the bottom represent a gene, and it's got a few genes for the translation or making of it, a few genes for the capsid, and a few other proteins for entering the cell and infecting. It is a flavivirus. The more familiar flavivirus is yellow fever. It's related to West Nile and some of the hepatitis viruses. It is spread by mosquitoes. The most common is the Aedes aegypti, and the possibility you may have been hearing about in this region is the Aedes allopictus. Fortunately, we don't really have either of these mosquitoes in this region, but they are prevalent throughout the southern and eastern United States. Transmission is also maternal to fetal, which is what has gotten this in the news. Blood transfusion, and then sexually has become an increasing worry, especially in places where it can't be spread by mosquitoes. It could emerge via that route. So to track this current outbreak, it was discovered in 1947. And the first true outbreak was in Yap Island in the South Pacific in 2007, where the majority of the population was infected. They have a very small population, and they didn't actually see any fetal abnormalities or really any other problems in that time. In 2013, it went to French Polynesia. They had over 28,000 cases. They're estimating anywhere from 30 to 70% of the population was infected. Again, we'll talk a little bit more about what they saw, but they didn't really notice a huge uptake in birth defects because of the relatively small population of about under 100,000 people in the region that was affected. It's since moved to Brazil, and it was the Brazilian authorities who alerted this 20-fold increase in microcephaly or fetal abnormalities. So a little bit about the mosquito. This is a principal transmission vector, Aedes aegypti. It also spreads yellow fever. It's actually known as the yellow fever mosquito, dengue fever, and chikungunya, which are related tropical viruses. This is a distribution. The top in blue is the Aegypti mosquito. This is the maximum extended range, or where they've actually found these mosquitoes. A similar subspecies, which is actually more cold tolerant, is the allopictus. That's in the green below. And that, as you can see, can move much further north, although in lesser numbers. It has not been proven as a vector yet, but we're considering that it could be. It's a similar range as the Culex mosquito. I'm sorry if there's any entomologists in here with my bug names. But that's the one that usually spreads the West Nile, St. Louis encephalitis, diseases like that. Symptoms of the Zika virus, actually extremely mild. 75 to 80% of people won't know they had it, will never know they had it, and will be totally fine. If you do know you have it, it's usually a mild fever, joint pain, especially in your small joints. You get a reddish rash, and distinctive from the dengue, you get kind of a conjunctivitis, which is just really red eyes, like a pink eye in both of your eyes. The fever is also lower than those other two tropical diseases which it resembles. So why are we so concerned about it if it's such a mild virus? Our main concern is this massive increase in microcephaly, which just means small head. And we're noticing a lot of babies in Brazil being born microcephalic. In addition to the microcephaly, we're finding that Zika-infected babies tend to have worse developmental outcomes than similar babies with small heads from a different cause. And we're not exactly sure why that is. We believe it infects a neuron progenitor cell, which is just a developmental stage in the human brain development. And not only does it make the small head, but it makes a small head because it's killing the neurons in several essential regions of the brain. So it's a small head because of a small, underdeveloped brain. There are also some other concerns throughout the nervous system, fetal growth restriction, concern for increased fetal loss. Looking at the numbers from Brazil so far, it is still a small risk. Of babies infected during pregnancy, we're seeing these outcomes in about 1%. But when you realize millions of babies born every year, you can be dealing with a significant, massive increase in developmental disabilities, and we actually don't know what's going to happen, how long survivability will be. And the risk does appear, again, this is all kind of conjecture, to be early in pregnancy. Women who have been infected later in pregnancy seem to have milder or less symptoms at this time. Our second concern for this is something called Guillain-Barre Syndrome. Guillain-Barre you may have heard of. It is an autoimmune system or illness that your own body immune system attacks the nerve coverings of your body. It has a range of neurological symptoms. The most severe is complete and total paralysis, including of your breathing muscles. This is usually recoverable in about 80% of cases. They go back to almost near full function. About the remainder 20% they will recover, they'll breathe on their own, they'll be able to walk, but they can have a lifetime of neurological difficulties. This happens throughout our country at a rate about 1 per 100,000 to 1 per 200,000, which is not an insignificant amount, but it's pretty rare. Where this Zika outbreak in Micronesia, we saw a rate of 1 to 2 in 10,000, which is a 10 to 20-fold increase. So if you were to get infected with Zika, you would still have an extremely low chance of having this. It'd be 1 in 5,000, 1 to 10,000. However, when you look on a population scale, having an increase in such a serious syndrome could be concerning. So this is just a little diagram of Guillain-Barre. The nerve itself is not damaged. It's just like a wire, and then that whitish material around it is insulation. And the neuron signal actually doesn't travel down your nerve. It bounces between nodes on those little myelin sheaths. And that's what allows communication to go such a relatively long distance at a very short amount of time. If you lose that myelin sheath, you're not permanently paralyzed. It just needs to heal, but you will not be able to move until that is healed. And if it doesn't fully heal, you will be left with permanent neurological problems. Usually this is in the peripheral nervous system, meaning your brain is fine, but your body has some trouble. So currently there is no treatment for this, and we don't estimate there will be by the time we identify it and treat it. There is some possibility of antiviral issues. Sorry, in the transfer, the picture got a little mixed up. Mosquito control is key and very our best chance of really keeping this in check. A lot of people don't realize, but in 1892, malaria was prevalent basically east of the Rockies as far north as Mississippi, and the entire Michigan, the entire Mississippi River drainage. And through ongoing mosquito control throughout the early part of the 19th century, or late part of the 19th century, early 20th, we've eradicated malaria from the United States. I mean, nobody gets malaria anymore here. And we have very effective mosquito control programs, so we will likely be able to control this fairly well. But that is probably our best bet until they get a vaccine. Other keys avoiding bites, we'll talk about that a little bit more. And there is, both in Europe and here and in South America, the Brazilians are working on a vaccine. There hasn't quite been a breakthrough yet, but it is reasonably possible we'll get a vaccine in a couple years. And then it will be a whole issue, testing for safety and everything, but it will be some time before a vaccine comes online. Prevention, if you're traveling to an endemic area, meaning an area where it's prevalent, you should wear long pants, shoes, and socks. Repellent should be DEET-based on people older than 3 months. Another effective one, if you have any trouble with DEET, is picaridin, which is also known as icaridin, is a very effective repellent. Mosquito, it's mostly a daytime mosquito. It's active in sunrise and sunset. And the good thing about this mosquito is it doesn't actually travel far. So we believe that the transmission at this time is within relatively dense areas. A mosquito that bit me here is not going to infect somebody in Powell. It might get somebody at the Buffalo Bill Center, but it's a very localized regional thing. So you have to have fairly close contact, again, we believe, to have an effective transmission. The other concern for prevention is that sexual transmission is a concern. We believe males may be able to transmit the disease up to 6 months. It's been proven to be transmitted through semen up to 3 months. So we recommend barrier protections for anybody who could potentially become pregnant, and then if a partner is pregnant, they should continue for the duration of the pregnancy. We are recommending anybody traveling out of the country to check with the CDC prior to going. So risk to Wyoming, here very low. We do not have either of those types of mosquitoes, and we're not planning on getting them. The Wyoming Department of Health said there is no risk. You know, things can always change, but it's very, very unlikely to see here. Transmissible. Just a side note, they don't like altitude. Any vector mosquitoes that transmits this, so anybody who lives above 6,500 feet, or even if you're going to Brazil or South America in a high altitude region, you would be fine. Imported cases, however, are very likely. We are likely to see these probably as soon as this summer, probably even here in Wyoming. People are going to come in, they're going to be infected. They're not going to transmit it to anybody here except through the possibility of sexual transmission, but that should be a relatively low transmission rate. But you will hear in the paper, oh, we've got Zika in this state or that state or even in Wyoming. Those are likely to be imported cases at this time. And there was just actually a thing yesterday in the paper, there may be 2,000 cases of Zika in the US already, and it's a scary headline, but it's not really as bad sounding as it is. Finally, these are the countries, if anybody's thinking about traveling as of this month, that are having active Zika transmission, not active cases of Zika. So pretty much the entirety of South America and Mexico, as well as New Guinea. Interesting enough, there's a massive yellow fever outbreak going on in Africa right now. However, we're not seeing Zika transmission there. The Caribbean is also seeing a fairly relatively risk of transmission. Now, this map has been floating around. It's relative risk of US cities. The bottom half is a risk during July. The top half is risk during winter. So if, for example, you look at Denver, which is our close neighbor, or Salt Lake, they're low risk in summer, and that's a theoretical risk because of the range of the mosquitoes I showed you, and they're high imported travelers, that there could be the rare possibility of 1 or 2 cases, but it's very, very low. And what they defined as low in this study was less than 2% chance of having a case in that city. So this map's a little misleading, but more importantly, if you see this area in red right here, these little things are counties that have reported dengue or chikungunya, which are transmitted by this, and there's a high chance of transmission in those areas, probably as soon as this year. July, August, we'll see if it does get that far up. But those are areas where if you were there, you would really kind of need to worry. And then the other shaded areas are at this time theoretical risks. And that concludes for me. If you guys have any questions, feel free to write them down. And after Lori gives her talk, we will come back. Thank you.
Hi, so again, my name is Lori Hipwell. I'm the pediatric nurse practitioner here at West Park Hospital, and I'm going to talk to you a little bit about pertussis and measles, something that we still continue to see, even with our vaccinations. So pertussis, another name for pertussis is whooping cough. It is a very contagious respiratory illness spread by bacteria, actually, that's called Bordetella pertussis. It actually releases toxins into the airway and causes the airway to swell. And that's where you get that whooping insignificant cough that happens. The important thing about it is it presents itself as an upper respiratory virus or illness, and So a lot of times you're walking around, you don't even know what it is until a couple weeks after, when you really start getting that whooping cough symptoms. And most people are actually most contagious for up to about 2 weeks after the cough begins. It's definitely more serious in infants and young children and can cause even deadly complications, especially ones that are not fully vaccinated. They have a tendency to be hospitalized more readily if they're less than a year of age. One of the big things you'll see with infants is apnea, which is a really slow or actual absent breathing. That's one of the symptoms that may alert you to a young infant sooner, as opposed to waiting until the cough comes. But they can have pneumonia, they can have encephalopathy, which is a disease of the brain, and they actually have a low death rate. In adolescents and adults, they have less complications, mostly because they've already been vaccinated. Most of the complications in older adults are associated with the cough, and that really consists of rib fractures just from coughing so hard. They can also have pneumonia as well. Some of the early symptoms, it starts with, as I said, the cold-like symptoms. You get a low-grade fever, a running nose, some mild occasional coughing, and then again in infants, that apnea or decreased breathing or absent breathing. Late stage symptoms after a couple weeks is when the paroxysmal coughing starts with the whoop, characteristic whoop. They can actually have a lot of vomiting because they are coughing so hard. They don't keep anything down. And it can last for up to 10 weeks. So this is a young infant. It's kind of loud. And is there any way to... I'm going to fast forward it just a little bit till we get to the point where you can actually... But that loud inspiratory is what is the whoop and characteristic of it. But you can see how much she's actually struggling to actually breathe and to try and cough. But that inspiratory loud is the whoop that you'll hear. So diagnosis and treatment, usually it's just the history of the typical signs of how it started. The physical exam, we usually do a nasopharyngeal swab that is sent off to confirm the testing. And the treatment is really early antibiotic treatment. So you really want to get that started as soon as possible. But again, it can be difficult because it can be misdiagnosed within those first couple weeks. It helps lower the transmission of the disease by starting it early and can have less complications. Care of the non-hospitalized child, you do not want to give cough medicines to it. Again, it's the swelling of that airway that causes all that inflammation. So a cough medicine is really not going to help with that. And you don't want to give cough medicines to children less than at least 4 years of age anyway. You want to get the antibiotics in as soon as possible. You also want to minimize any irritants that could actually cause a coughing fit, like smoke, going outside if it's really cold, those kind of things. Supportive care with a vaporizer that we do for upper respiratory infections anyway. Small, frequent, if they're having a lot of issues keeping fluids down and even food with all the coughing, and if they have a lot of vomiting associated with that, you want to give just frequent small meals, small amounts of fluid very frequently so that they can keep that down and prevent dehydration. This is a graph of identifies the history of the pertussis cases from the early 20s to most recently 2014. You can see where the DTP in the 1950s, the vaccine was initiated, so you saw a marked decrease in the amount of cases after that. The graph up on the top is just a in-depth version of this little section here where we saw a little bit of an increase 2004, 2005, and then also started doing the Tdap boosters. But we still have seen an increase over the last several years of cases of pertussis. This is a graph reported by age. The top line, the pink, is less than 1 year of age, so you can see that it's more prevalent in that age group, and again with more significant complications, mostly because they haven't been vaccinated yet. The next group you see is the orange line, and that's the 7 to 10 years of age, and you see a little bit more prevalence in 10 years of age, but they actually ended up getting the Tdap booster at about 11 or 12 with their immunization schedule. So prevention, vaccination. The Tdap is a combination that protects against diphtheria, tetanus, and pertussis. It does fade over time, and that's why you need the booster. It's especially important to pregnant women because it can actually provide a short-term protection to the infant before they actually start getting vaccinated at 2 months of age. You want to protect infants and children from sick contacts, and it's also suggested and a good idea that if you are pregnant and you're going to have any family members that have not been vaccinated, we'll be caring for the child, we'll be around the child to actually have them vaccinated as well to protect the child. Measles. So measles have been around for a long time. It was first identified in the 19th century. The first vaccine was available in 1963, and prior to that, almost everybody that came in contact with measles, all children had it before the age of 15, which was kind of surprising to me when I did a little research on it. Up to 4 million people estimated were infected every year. Numerous people died, many people were hospitalized, and it can also affect the brain and have some swelling of the brain. They also had an outbreak back in the 1989, early 90s in school-age children, but also on some college campuses that at that time they suggested a second dose of MMR for a booster. It was actually declared eliminated in 2000, and what that means is basically there's just an absence of continuous disease out there. It's still there, it's still prevalent, it's not gone all the way, but it's just not, no cases were identified within a year. It's a highly contagious virus, so pertussis is a bacteria that can be treated with antibiotics, and measles is more of a virus, so the only thing that you can do to treat it is actually vaccinate against it. Very contagious. 90% of all people will get infected with it. They come in contact with an infected person. It can live up to 2 hours in the air. You're most contagious from 5 days before the rash starts to about 4 days after the rash appears, and the rash begins to fade about 5 to 6 days afterwards. Of course, children less than 5 years of age are more likely to have complications, as well as older adults. It is the leading cause of death in young children globally. And actually in 2014, there was about a little bit more than 100,000 cases around the world, and the World Health Organization instituted a global vaccine for it, and it actually decreased the amount of deaths by about 80%. So signs and symptoms of measles, you see this typical rash. Symptoms usually appear 1 to 2 weeks after exposure. You usually have a really high fever, a cough, runny nose, and again with the conjunctivitis, which is inflammation in the eye. And then several days after that, you get the Koplik spots, which it's really kind of hard to see, but they're little red spots that have kind of a white center that you'll notice in the mouth. Those begin to fade after several days, and then about 3 to 5 days after that is when you start seeing this lovely measles rash. Starts on the face, moves down to the trunks, and then to the extremities. Most of the complications are in the young children, as I said earlier, ear infections, diarrhea, pneumonia. They can develop an encephalitis, which is a kind of an inflammation in the brain that can lead to learning difficulties and can cause deafness down the road. Okay. A small percentage actually can die from measles, and it can be it can certainly cause premature birth in women that are infected with it. There's also a very rare and fatal disease called subacute sclerosing panencephalitis. that usually develops about 7 to 10 years after the initial infection. And it's a horrible, horrible disease, and it is fatal. Most of the research has shown that if you contract measles when you're less than 2 years of age, you're more likely to have this as a disease later in life. Again, no treatment. There's no antiviral treatment. It's supportive care. You want to make sure that they are not getting dehydrated. Antibiotics are only given for complications if you have pneumonia or the otitis or things like that. Prevention, it's no longer endemic, which means it's not constantly present in the United States. Most of the time it's bought by unvaccinated travelers from overseas, Asia, Europe, England, France, Germany, that don't have a good vaccination schedule. And that's where most of these cases in 2008, 11, 13, and 14, there was definitely an increase, as you'll see in a chart here in just a little bit, but thought to be brought by unvaccinated travelers. And also we've seen a rise in not wanting to get vaccinated for concerns for all the autism and everything that is circling. So there's actually pockets of communities that children are not vaccinated, so a lot of these were taken from those areas. The vaccine's very effective. We usually do 2 doses, and it's 97% effective. So these are the cases from 1962 to 2011. Again, you can see when we initiated the vaccine in 1963, we had a marked decrease. And then again in 1989 and 1990 is when we had that outbreak and recommended the second dose of a booster. And since then it's continued to fall. Vaccines for Children program started in 1993, and in 2000 it was basically declared eliminated, but still present.